Hello and welcome to the Health Science Podcast, sponsored by the National Health Association. I'm your host, Dr. Frank Sabatino, and I'm delighted to have as my guest today, Dr. Micheal Lenz. Micheal is a medical physician who is board certified in pediatrics and internal medicine. He is also a diplomat in the American College of Lifestyle Medicine and on the board of diplomat on the board of lipidology. And he has a really interesting book out right now called Conquering Your Fibromyalgia. Real answers and real solutions for real pain. And we're going to get into all of that. Welcome, Dr. Lenz. How are you? Welcome to the Health Science Podcast, brought to you by the National Health Association, the oldest organization in the world championing the extraordinary benefits of a whole plant food diet and healthy lifestyle, as well as water-only fasting. We believe that health results from healthful living and focus on evidence-based science that promotes the health of you and your loved ones, as well as the health of all animals and the environment. We feature experts from a cross-section of disciplines within the plant nutrition, vegan, psychological, environmental, and animal compassion sectors. I'm your host, Dr. Frank Sabatino, the NHA's Director of Health Education.
Oh, great! Thanks for having me. And
thank you for taking the time to join us. I know that as part of your overall plan, we'll get into this as we get into the conversation. You do advocate and have really participated in your own life in a whole foods plant lifestyle in terms of nutrition. How did that start for you? How far back does that go for you? What was the aha moments in that journey?
Well, like lots of things, there's pieces along the way. I somewhat joke that I was a part-time vegan, so to speak, in med school because it was too darn expensive to buy meat, and I lived off of a lot of pasta and marinara sauce. The first date we went on with my wife and I when we were dating, we went on a run, and I came back and I was cooking my same old pasta marinara sauce, and my roommates gave me a hard time because they were grilling chicken on the grill. This was way back in the early 90s. But so I heard about in the 90s when I med school, 92 to 96, and I heard about Dean Ornish at the time. And I remember asking an attending on the ward something about it. It wasn't the internet, and, there's so much you're learning. And the comment was, well, yeah, but you basically need a dietitian to teach you how to cook all of that. And it's really hard. And besides, nobody's going to want to do it anyways. Who's really going to do it? And so I heard about it. And then you're taking the drink from a fire hose of all the information you're going through. And then my wife, who's a dietitian, like I've heard on some of your guests, she had continuing education done, and and I always was interested in kind of nutrition and got into lipidology. And when I found out at age 33 through advanced testing that I was actually at high risk for developing heart disease, had elevated C-reactive protein that was moderately elevated lipoprotein A. At age 33, I got a calcium score. The score was about 12 or 10, which is not something I recommend anybody under 40 normally to get, but I didn't know what I knew because usually you don't find anything that early. So I was taking statin with niacin and eating a decent diet. Ironically, I had a particle number of 2,100. For a week, I just ate a bunch of vegetables. I got it repeated before I went to a lipidologist, and it dropped to 1,600. I couldn't admit to the lipidologist that. She's like, wow, did you do anything different? And I didn't really say I did that much different because that admitted that you were doing something bad. It dropped 25%. But still, based on my labs, in my family history, I needed to get it down lower. Fast forward, there were two things that happened simultaneously. Two studies came out showing that niacin added to a statin had no added benefit for cardiovascular reduction. And my wife said, hey, here's this book called The China Study. You should think about reading it. So I read it, and then I started reading more, pulling up Ornish and Neil Barnard and reading all of this. And then basically I went essentially plant-based that summer. And then The Forks Over Knives came out over Christmas. My brother said, hey, you should watch this. And I'm like, wow, that's everything I've read into a nice documentary that I could just tell patients. And I'm like, you know what? I'm 100% doing this because I want to do it for my health and to be a model for my patients. And pretty much went from there. I have been very enthusiastic about it, but sometimes I've learned somewhat to curb the enthusiasm because not everybody in your health system always has the same understanding. So I've sometimes have had to balance lots of things like a lot of people in the world. And I've heard other people talk about this, that I kind of assumed that if I was a good doctor, everybody would just do this because it's so obviously good in the evidence, but it's actually harder to make changes for patients. But that's a quick story of my plant-based journey. And I've
Well,
been encouraging people
what
to
you needed to tell that doctor when he was asking you, did you make any changes? You just had to say, well, yeah, I married a vegan dietitian. That's all you had
Yeah,
to say. That's all you had to say.
I know. But at the time, it's like admitting, like, oh, I did something different. But yeah, way back when. And so, but yeah, so then, it's been such for health reasons. I have family history of heart disease and diabetes as well. So there's lots of reasons and to do it, and all of the, great health reasons.
Well, when I was reading your book and looked at what you took on, I was sitting here thinking, Dr. Lenz is kind of a glutton for punishment. Here's the reason why. We live within a working medical system where, of course, people go into medicine, doctors, and so on, because I really believe somewhere they want to help people. I mean, I don't have any question about that. Political and economic medicine and pharmaceutical companies may be a different animal, but as a rule, the day-to-day physician, I think, is trying to do some good for people that he has to work with. But you're educated through a system that in a way trains you to be a disease manager and not really providing what we'll call true health care, where you have this sense that these major chronic diseases not only can be prevented, they can actually be reversed. And of course, that's not part of your training. The training is that, no, when you have these things, they're kind of stuck. So now fast forward, you decide to take on what I'll call the werewolf of medicine and fibromyalgia, because it crosses so many body systems in an age of specialization where people don't believe people can recover anyway. Now you've taken on this kind of black box problem. So talk to me about how that evolution kind of occurred, that interest in, I mean, I know you were interested by the fact that you went into pediatrics, and internal medicine tells me that you were already looking at bigger pictures of people and systems rather than isolating in one, minute focused specialty.
Yeah.
So I know that was part of you. So talk about that evolution just a little bit, how you came to this werewolf of medicine in your own mind.
Yeah. So, like you said, internal medicine and pediatrics, I have always been very curious, and I have a medical student who I get a chance to mentor now, and he's just starting first year and getting experience, exposure, shadowing, and basic history taking in clinic. And I was talking to him today and about which one neat thing about what I do is I see all the different organ systems, and it's not just one. And because of that, you get to connect things. And as a pediatrician and an internist, we like to have a very in-depth understanding of non-surgical management. So I always was interested in that. And then going back, we had problem-based learning, a little bit of that in med school in 92. And we picked a disease, our little group of 4 people, and had to dive into a whole kind of what we call now biopsychosocial spiritual model of understanding it. And our group picked depression. And we had a psychiatrist as a mentor and guided us through that. And I really understood, as is pretty common now, and kind of back then, that's where fibromyalgia was, is that people kind of accepted that it is real. And a lot of people get this, and it's caring and compassion. My mom was a nurse. She helped support people in mental health. And so I've always had that interest in mental health issues and understood that was an important thing. And I never really went into med school thinking hypochondria was real. I thought there was something always more behind that, and, wanted to trust the patient. So along the way, what I was thinking about the other day, that so much of what we learn in training is sick medicine, as we'd call it now, hospitalized medicine, especially in that world. And there's needed things like you go to pediatrics and you have developmental conditions that, genetics, et cetera, and holes in hearts and cystic fibrosis and all of those things that come up that you have to treat. But a lot of what you do in outpatient medicine and in primary care are chronic pain conditions of various stripes. And what I started to recognize is that there was a family history of things. You start to dive in depth, and oh, well, you have migraines, but your mom had bad IBS, plus she had chronic, quote, arthritis, which really was probably some fibromyalgia. And I just started constantly reading. I heard about fibro in the late 90s, but it was sort of, what is that? And I kept learning and reading and more. And then Dr. Daniel Claw from the University of Michigan, and a lot of the research he did looking at functional MRIs, which I talk about in the book,
Right.
and trying to bring that to light, was, wow, this is real. And then trying to see how all of these multi-directional, intersectional things that play a role, truly the biopsychosocial spiritual model intersecting in so many ways, and trying to integrate it. And I've said to patients of mine who struggle that it's not that exciting to help somebody get better from a urinary tract infection. But when I look at it as the duration of time and depth of suffering that somebody has, and then if you can make them better, boy, the reward is equivalent to the amount of suffering, because they've had so much. So it's so rewarding to help people reverse or push back to the levels of pain and struggle that they have, and often using a really multifaceted approach, blending the best of things like lifestyle medicine and medical management to the best of you can, and trying to do that with a lot of education. And part of why I decided to put this stuff in the book is because I was waiting for somebody to do this. And if I'm like, well, no, who's going to do this? I'm waiting for somebody else to do it. And I thought, well, I might as well put together what I've shared. And it started as a 2-page handout for my patients, then a 20-page handout, and that wasn't enough. And because of limited time, I said, I'm going to write a book to be able to have patients really get an in-depth understanding, so that this is, a lot more to buy. As I say, one of the chapters is the buy-in. You have to buy into this concept, and then use this multifaceted approach that's not going to get quick necessarily overnight, or it's, even if you make 100% diet changes, that often takes weeks to make those changes. So I just decided to do that. And then after that was COVID hit, and I'm like, well, I might as well finish the book off, and got a chance to work on that and finish it. And I'm continuing the conversation with the podcast too.
This idea of looking at a problem like this, well, the fact of the matter is, any problem that anybody has in health, I've always found that there's always a constellation of factors that contribute to that, whatever they may be: biological, sociological, emotional, and so on. And so that's typical of most things. It's also typical that people don't pay attention to those things. So as you've gone through this now, before we get into the nitty-gritty of the problem, have you found more people that are taking a more integrated approach, like you have really pioneered in certain ways in your life, where they are really dealing with these cross systems, the fact that it's affecting and really crossing what would be so many different specialties of orthopedics, neurology, neurobiochemistry? All of these things are part of the kinds of things you're looking at. And I still believe it's probably very foreign for someone who comes out with traditional medical education to make that kind of leap of faith into this idea that, wow, this is something bigger than just sending someone to a psychiatrist or to a rheumatologist or to an orthopedist or to a neurologist. So the person has to be someone with a mindset very much like the one you've described for yourself. Have you found that to be more prevalent now after all these years of doing this, or is it still pretty much, are you still pretty much a pariah in this?
Yeah. So, my patients, are so appreciative of the work I do with them, and being able to help them. And when you've had people, I share some of the stories on my podcast of people who've been able to turn their life around, integrating all of these things. So it's individually as my patients, as you've known, when you have evidence-based medicine, you want to apply it, whether it's reversing diabetes, blood pressure. And my wife has helped me reframe sometimes some things. And one of the things that I share with my patients is that, well, my patients who do this, we have to stop a lot of their blood pressure medicines and often get off of them. My patients who do this, we really have to watch their insulin levels and blood sugars, because if they do this, they're going to get off. My patients who do this, it really helps. And I kind of put a little challenge. I know it's really hard, but when my patients who do this, so it's kind of like using some of that psychology of it's hard, but let's try this. Let's look at this. And
Right.
part of it though too is, integrating and bridging all of these dimensions, which what I've learned in coming into this community, in people who've been in the community as patients, who are patient advocates in this world, is they were testing me, so to speak, to make sure that I was not selling snake oil, that I
Right.
wasn't just giving them some kind of thing, which is part of what motivated me to get the book, where you'd have some book on fibro and it's 80% good science, and then there's 20% not so good, and then they're selling a supplement at the end of the book or a special concoction. And when the community that understands and has accepted me with this, when the fibro and world of things, is they know when you say it's a multifaceted approach, there is no one quick fix. They really know that I get it, because they've tried one quick approach. They've tried
Right.
those things, and they know that it's not so simple from here's a penicillin to take the strep throat away.
Right, right. And that pressure is provided also on physicians by the patients themselves, because in a way they've been brought up to think about looking for magic bullets and quick fixes. So now when you present with a problem like this that is so multifaceted and it's not going to change in 5 minutes, the patient themselves, I would imagine, if they're not versed, or if it's a newer problem to them, would almost be reactive in like, well, what do you mean? You can't just give me that, that one script that's going to take care of this. So the doctors, I think, have that pressure too, where they're feeling like, they're being dictated to almost by the system itself, which almost seeks out magic bullets, because we've had issues, like you mentioned, with antibiotics treating basic infections, things of that nature. I'm here with Dr. Micheal Lenz. We're going to take just a few minutes to hear from our sponsor, the National Health Association. Dr. Lenz is the author of Conquering Your Fibromyalgia, and we'll be right back. You're listening to the NHA Health Science Podcast. Dr. Frank Sabatino here, encouraging you to check out the NHA membership. For just $35 a year in the US and $55 internationally, you'll have access to a wealth of resources, including our quarterly full-color print magazine, Health Science. Stay updated on the latest health tools, inspiring stories, and exclusive events like the NHA Conference and plant-exclusive cruises. Join us at healthscience.org/membership and make a difference in your life and the world. I'm Dr. Frank Sabatino, your host, and now back to the NHA Health Science Podcast, where more exciting insights await you. Welcome back to the Health Science Podcast. I'm your host, Dr. Frank Sabatino, and I'm here with Dr. Micheal Lenz, who has a book out called Conquering Your Fibromyalgia, which is a really intriguing, multifaceted problem that keeps people in the arena of suffering over very, very long periods of time, to try to find some way to understand the constellation of things that they need to sometimes look at to help resolve this situation. So let's talk about fibro itself now, Micheal. You make the point that there is about 4 million people you feel that are really kind of suffering with this problem. I'm assuming that doesn't include all the different comorbidities that are associated with this too. I mean, because you make the point that when you have this, you have predispositions for so many other things, including things like restless leg syndrome, attention deficit hyperactivity disorders, chronic fatigue, irritable bowel. So, when you start talking about all of those symptoms, I could imagine that 4 million maybe is a kind of an understatement to that problem.
Yeah. And actually, since that went out, it's probably closer to at least 10 million in the United States in fibromyalgia. And a lot of these things are, I have somebody I interviewed on the podcast and who has chronic pain. And she's like, well, I haven't been told I have fibromyalgia, but I don't know what I've really been told, but I've had chronic pain, and they've given me all these different diagnoses. And I've had patients come in and it says things on their chart, and you do the widespread pain index, and you're like, well, you actually meet all the criteria for fibromyalgia. But a lot of people have this, and then you look at migraines, IBS, all of that is under one basket, if you want to call it, of that central pain processing struggle syndromes.
is one of the hallmarks for you? I mean, if we want to simplify this a little bit for the audience, is one of the hallmarks that it is basically non-inflammatory soft tissue pain? Is that what we're really trying to see, where there's not really traditional inflammatory markers and so on that would suggest something else? Is that one of the
Well,
hallmarks?
one of the two things, and this is a important thing, is that it's the nervous system, the central nervous system, the brain, spinal cord, and brainstem, and how they process stimuli. There is a alarm that goes off that gives the experience of distress that is not commensurate with the amount of tissue damage. Now, one of the key, more updated things is that they used to said, well, if you have rheumatoid, you can't have fibro. Actually, a lot of people, about 40% of people with rheumatoid arthritis also have fibro, and similar to things like those who have inflammatory bowel disease, about 40% also have IBS.
Stop right there. When they have those concomitant conditions in rheumatoid and so on, you do have all those inflammatory markers. So the truth is, you can be dealing with fibro and still have a sideline of a whole series of other inflammatory changes that are going with it. And that makes it even more confusing in a way.
And that's a newer understanding. I say newer, probably in the last 7 years or so. But with things like this, a lot of people don't understand. So it's not yes or no. You can have osteoarthritis in your knee and have also fibromyalgia, or you can have these, and there's amplification of that on top of that, so it's a little bit tricky, but one of those is just understanding that it's kind of like having a different software operating system within the brain, how the brain processes input and then how the person experiences it. So as you read in the book in other areas, that it's the functional MRI looking at oxygen use within parts of the brain, showing that people experience pain at the same intensity when you look at the classic thumbnail pressure, and they experience pain, but it was, instead of 4 kilograms that a normal person would have, it was half that, but the experience was identical. But 2 kilograms of pressure on the thumbnail wouldn't give tissue damage, but maybe 4 would start to do that.
So that amplification is kind of intriguing. That what you call that central pain sensitization is interesting, because we know that when information comes in, somatosensory information, pain stimuli, whatever, you're going to have reactions in parts of the brain, the thalamus, places of that kind in the brain. And yet then there are descending modifying pathways that kind of fine tune that. And it seems that both of those things become haywire in a sense. You get an amplification with less descending modulation, so to speak.
Yeah.
And so it creates this amplified experience, as you said, out of context of the stimuli, so to speak.
Yeah.
And it's very reminiscent to me of the process of allergy in a way, if you think about it. When if you think about the immune system, it's really programmed to react very forcefully to very dangerous stimuli, and not so forcefully to things that are not that much of a challenge or a stress. And if you think about it, a strawberry is not a major stress to the system, but the immune system's acting like it's almost a life or death situation. So it's that kind of, you're getting that kind of amplification process. I would imagine you'd probably even see a lot of allergic type responses with fibro as a concomitant to some of these amplification changes.
Well, actually, now as I'm learning, as this continued understanding, is mast cell activation syndrome probably really falls under these central pain processing disorders. We look at POTS, postural orthostatic tachycardia syndrome. All of those are interesting. I've even had patients, as I'm learning more about this, will have had a history of these idiopathic rashes. All of those idiopathic urticarial patients that you didn't know weren't clearly allergic to anything probably really fall under this autonomic dysfunction when there's a inappropriate reaction, and body reacts and an alarm goes off of distress, and it's not because of a true threat.
And the thing that you posed, I really love the discussion of catastrophization of pain, because it's kind of intriguing that when we look at a lot of stress and stress response, we know it's not so much the event as much as the perception of the event that really creates a lot of the negative outcomes. And this is a classic example with fibro, and especially if it's concomitant with things like ADHD, where they're just the anticipation of that pain, the fear of that pain, the way that they look at the terrible nature of what they expect to experience is actually creating much more significant pain than if they could focus their attention in other ways. I find that that's a very fascinating part of how the mind-body connection really works. And I didn't really think about that in relationship to this problem, and you presented it so beautifully. But here's where I have some issues, and I want to go over these with you, okay?
Sure.
Because it's important to me. I understand that when you have comorbid conditions like restless legs, for example, and it's going to interrupt sleep phase, it's going to interrupt sleep. Or if you have ADHD where you have a difficulty in planning your day or feeling overwhelmed by the events of your day, and then you have either hyperactivity or inattentiveness because of those conditions, that you feel that the arsenal for really dealing with this is working with certain forms of medication that you feel are almost essential to address those a priori so that they could kind of get on with the real work of healing and repair that has to occur. I mean, that's one of the things I picked up. And then I know in treating ADHD to improve focus, you make the point that ADHD and even fibro are dealing with kind of deficiencies of certain transmitter systems, for example, serotonin, norepinephrine, and of course, the end product of the pleasure cascade, dopamine. So the interesting thing for me, though, is, and tell me where you want to take this apart, my problem I have is that when you look at the way neurotransmitters work in the brain, there's always this end product inhibition. So that if you continually put in something that mimics what the brain or the body produces, it will tend to stop producing its own. When you provide psychostimulants, you are increasing dopamine release. You are down-regulating dopamine receptors in a lot of the pleasure centers of the brain. So in a sense, you're creating a certain dependency to those meds over time. And that, to me, if you're treating a child or an adolescent or even an adult, it seems to me that while I understand the mentality, because you want to get rid of that perseveration, you want to get rid of that inattentiveness, you want to get rid of the things that are procrastinating them, preventing them from making a clear plan of how they can get on with their lives. How do you walk that fine line for how long you take and stay with that kind of treatment that in the long run could end up creating its own
Sure.
dependencies on a neurological level?
So one of the classic ones that I talk about in the book is opioids.
Right.
And we understand that opioids get that classic, it works for a while, and then you go up on the dose, and it works for a while, and then you have to go up on the dose. The neat thing about these medications, and I've been treating kids who have ADHD since 1996, and with that adults, is that when you get the right dose, the dose doesn't change. In fact, if the dose stops working, I'm suspecting there's some kind of disruption in sleep. But this is one where you don't get that tolerance, maybe somebody like cocaine where you get higher and higher, or opioids is a classic. So when it plays out, you don't get that tolerance. And I kind of use the analogy, it's like getting glasses, right? I need glasses. If somebody took away my glasses right now, I'd be very frustrated trying to function without them. I need to just get the pair of glasses to at least get at the same playing field.
So your feeling is that when you discover that stable dose, this is something they would stay on for life, like you wearing glasses for life.
Yeah, it's just like getting back to that maintenance level. It's not something that
because if you took them off, they would go through withdrawal. There's no question.
No, they would go back to the same where they were before.
Right.
I would go through withdrawal if I can't see my glasses because I know what it's like to see, and I'd be very frustrated.
Yeah, but this is actually on a chemical level they would withdraw, because the down regulation of dopamine receptors and actually dopamine release would have to recalibrate. And in that period, that's what withdrawal is. So there would actually be a more severe withdrawal effect.
So I don't, that's not something I see with my patients.
Well, because you don't do it. I mean, you keep them on a stable dose.
Well, no, I have patients who, because of shortages now, patients who go because they can't get the medication. It's because they have people who maybe I don't take it on the weekend or things like that, their own personal things of how they forget or whatever, go on vacation, they didn't take or whatever. They don't have it, if they don't have any withdrawals per se. Like if somebody went on opioids, and they're on opioids, a daily opioid use. And as a side note, probably around 2002, when we were getting told, and I came through all of these, the extra vital signs, and was in residency, finished in 2000 when they were selling OxyContin. And I remember having a patient of mine who ironically was a narcotics detective who had the worst luck. He kept injuring himself. The fourth time he fell out of a golf cart in his 40s, and he needed OxyContin again because the other stuff wasn't working. I go, hey, I'm going to do this pain contract. And he's like, what? You don't trust me? I said, that's it. I'm never writing another script. This stuff is addicting. But getting back to what is some of the other things that may be going along with it. Interesting, that's often comorbid with ADHD. And part of this is we're learning more people who are on the autism spectrum, which wasn't in the book because I wasn't aware of that, also have a hypersensitivity. We don't use medication to treat autism per se, but it's a huge part of that education. There are patients who can not treat their ADHD in the medication standpoint, but they usually have a job that is in a highly creative field, very hands-on, and their hobbies tend to be very hands-on, physically active, highly creative. And if they can pair themselves with somebody else who does the executive functioning for their life. So you think of Bill Gates, Steve Jobs, a lot of those superstars, they didn't get treated, but they were able to pair themselves with those, the people who aren't as, Paul Allen and Wozniak and a lot of those people who were able to use those talents with that. So that's why there's a lot of people who don't get fibromyalgia because their whole life they may have been athletes. Right. And they were partially treating it. There's a small percentage of people who, for an hour of aerobic exercise, can get pretty equivalent to 4 hours of maybe Ritalin. But when they get injured, and now you literally cannot exercise, they blow out their ACL, they cannot work out at the level. That's often why some of that heightened pain tolerance comes in. And there's other resources that are really can get dopamine up there, like playing music, creating art, being creative. So it's one piece. The reason why I talk about it some in the book, or mention in the book, and my biggest chapter in the book is actually talking about a whole food plant-based diet. Spend my biggest chapter talking about it because studies have shown that has been shown in some studies and also with experience reducing these fibromyalgia symptoms in half, which is more impressive than medication.
I want to get into those pillars of lifestyle medicine, but before we do that, I just want you to let people know, where they can find you, where they can find the book. What's the website location where you want to direct people to go?
Yeah, so if you want to go, I have the book and podcast, conqueringyourfibromyalgia.com, and you can look at some of the blogs I have and a lot of the podcasts and a lot of stuff that we're talking about. You get to have a long form conversation. I have over, I think, 120 plus episodes now, which dive in, and I get to have experts talking about all different types of things from diet, lifestyle, and other strategies of how to live better. I do a lot of things in my private practice, or my practice, I should say, that is not just chronic pain related issues, but working with diabetes, heart disease, lifestyle. I have patients who come and they just want a doctor who actually supports and understands the importance of a lifestyle and support them on their journey and understand that it's not weird to be eating whole food plant-based. It's actually the healthiest thing to do.
Well, you take time. They're looking for someone to take time to listen. Let's be realistic. Everybody wants to be heard. And, many times in medicine, as you know, there's such limited time in a practice. There's such limited time in a visit. And it almost feels very mechanical. I mean, I've had people complain about that all the time. So the fact that you have the opportunity to take time and address these other factors are important. Let's talk about exercise a little bit, because when we even look at things like depression, really good exercise regimens have performed as well, if not even better, than many of the SSRIs and other drugs that have typically been used to focus on this. And in this case, the idea of exercise, really devoting your attention to something like that and distracting it away from your constant preoccupation with your own pain has been actually a very useful tool for people. So talk about that, what kind of exercise, the regularity of that, and how that works in your practice.
Yeah. So it's depending where everybody's at, right? And everybody's got potentially functional limitations, right? From injuries, stenosis, who knows what. So one of the things is get a baseline. So if somebody is walking and counting steps, I'll have people say, well, if you can get a step counter for the first week, kind of do what you were doing. And classically, we'll see with people with fibromyalgia, they have a roller coaster. If we plot their steps on a graph where it varies and goes up and down, and say, all right, let's take the average. If you're averaging between 1,000 and 5,000 every day, get 2,500, perfectly space that out throughout the day. And then if you can, as best you can, every week increase that by 10%. So movement of whatever it is, and walking, if you can do that, if it's just getting up and going for a walk for 5 minutes throughout, and just if you can, or whatever, spacing that throughout the day, and then gradually going up on that over time. Whatever you like to do, of course, you're going to do that. But whether that's swimming, biking, walking, whatever you enjoy, and then gradually going up, starting low and going slow, because a lot of times people go, I tried exercise, it didn't work. Well, It's because they did too much. Then they have too much pain. And what studies have shown is that exercise can actually turn down or activate that descending pain pathway. So it helps distract you. Interesting kind of thing is that most of my patients who have this and may have ADHD with it as well find that outdoor therapy is much more interesting to them. Getting on a treadmill to walk for 90 minutes, going up and down, watching their show is hard to do compared to walking in a nice state park for 90 minutes. But I'm unfortunately not living in Florida like you are, I think, Frank. And we're heading into a real tough time for people with fibromyalgia.
I know the winter months are tough. Yeah. But you know what? It's interesting that you bring that up, because the connection with nature, so moving in parks, moving around where there is actual life around you, has been so powerful for even people on spectrums with autism and so on and so forth. So that's a really important point. And I'm that way. I've gone to gyms. That's not really my thing. I prefer to walk outside in the sun and the air, but in the winter, you've got to adapt to something else because it's too cold outside and brutal. But I think your point of being outdoors and getting as much of the connection with nature and life is a good way to trigger some of these beneficial changes that go on in the brain, especially, and I got the other thing is that, again, with this population of people that are suffering with this, because of the comorbid situation, sometimes the motivation and consistency can be somewhat difficult. So you emphasize the idea that you don't want to do like 100 steps one day and 14,000 the other. You want to kind of get into a kind of a more steady state of consistency if you can. When you know that that's true and someone's having trouble with that, do you link up with people that may be cognitive therapists and people of that nature who can help sometimes with some of the mental mindset of that? Or have you found it's not necessary to do that?
I just working with Medical College of Wisconsin, where I just started now about 4.5 months ago, and got a chance to talk with the pain psychologist here and hoping to incorporate that. And I actually just had on my podcast Dr. Afton Hassett from the University of Michigan, who's a pain psychologist, and she had a book out called 30-Day Pain Reset, and she has all of these great activities that you can do to help reset. Really neat. I just literally at the time, the second part of the interview was live today. And so what's nice is not everybody has a pain psychologist that can access. And so this is a tools, and they have all of these other things you can try, kind of a menu of options, which is really nice to offer that, because getting connected. And then that's also, as I talk about in the book, the podcast, is if a patient and their loved one, their spouse, their partner can be on page, then they can help in a positive way, coach, encourage, understand. One of my colleagues who working with a system at now, he said, hey, Mike, I just saw this patient of mine. She's been in the ER 3 times in the last 6 months with these recurrent severe abdominal pain. All the lab CT is normal. I did the widespread pain index and said, hey, you got fibromyalgia. She also had some comorbid restless leg, treating that with some medication. And he said, hey, I only have 30 minutes. I want you to listen, read Dr. Lenz's book, listen to the first season of his podcast, and come back and see me in a month, because he needs to recognize that extending that education, and we talk about that, the exercise, and then if everybody can be on board, okay, that makes sense. So I like the book with Dr. Hassett because it does get into a lot of those other complementary ways to help live better.
Right. And I imagine you've got to work with the partner sometimes, because if you think about this, if someone's been dealing with that kind of pain and dysfunction for such a long period of time, the person that they're with has a little bit of what now is being called compassion fatigue, meaning that, they've been kind of like a caregiver, and I think they kind of lose their own interest in being supportive of that anymore. So I would think that there's almost like a co-counseling part of that, so that the person feels that they can invest their time again, and there is hope. So I think that biology of hope that you're providing by this integrated approach is such an important piece for couples and individuals going through this kind of discomfort.
Yeah, and I had a lot of patients just share, people who've read the book said they've cried after reading the first couple chapters, because they go with it weaving in the stories of patients, and that, wow, this is a doctor who actually understands this and to, like you said, be listened to, but it's not just to be listened to, but also to offer explanations, understanding. I've used the analogy, it's going through this is like being blindfolded, bound, and tortured by an unknown assailant without any recourse. And I hope to begin by at least taking off the blindfold. One of the challenges is, as people will email me from across the country and go, hey, do you know anybody in Maryland that does the care that you do? Do you know anybody in California? And I'm realizing not a lot of people do this. I think part of it is, it's too much work. I don't got training. I don't want to go down that road. I'll just send them to the pain clinic. And sadly, the pain clinics are geared for doing procedural treatments. Often, they do some of the pain psychology, but they're not using a truly holistic approach, talking about, I guess, partially holistic. Some places are, like University of Michigan, and I think a lot of some of the places, but they're not getting, I think it's comprehensive of care is,
and the conventional pain meds and so on are not going to work anyway. That's the problem. So if you're going that route, it's really, again, a whole nother avenue of failure to a great extent.
Yeah, especially the opioid pain meds actually probably make it worse.
And I saw that it only makes it worse. Let's get to the rung of the exclusive plant-based approach part, because that's a really interesting piece. Again, you've got a couple of issues here. I know that when you have the comorbid states with ADHD, there is a much greater tendency for obesity and people, going off track with garbagey foods as a way to handle stress, because it's a quick fix for dealing with issues that they really don't feel able to handle on a routine basis. So let's talk about the power of whole plant nutrition in your 360-degree approach that you take.
Yeah, it's so important. And that's, again, getting the family on board, and the spouse being on track and understanding that this is, the evidence is there, sharing with patients, look at IBS, you're looking at fibromyalgia. And so probably like you've worked with patients, for many, they've never heard this concept before. They've been to many doctors. Right. And it seems radical. But again, I say, you know what? My patients who do this feel better. Their numbers get down. They lose weight, less pain, more energy, better sleep. All of these work together. And that's where there are dietitians who across the country, my wife's one of those included, that helps people integrate that. We have these powerful medications now that activate the GLP-1 agonists. I talked about that in the book. And if you just eat the whole food plant-based, get the short chain fatty acids, they act the same way. We can't afford to give $1,200 a month for, when you talk about rebound of medications, once you remove that, as you know, the medications go back, and I don't think you get the cancer prevention and all the other outcomes you do when you're actually eating the food.
Oh, and those people on GLP-1 agonists and so on, they're dealing with chronic nausea, projectile vomiting, all kinds of stuff that can be adverse. It's ridiculous. But I really appreciated, and maybe you can spend just a few minutes really talking about that this constellation of issues you're dealing with is really responsive to the gut-brain connection. And that's something that I think has become more brought to the surface, how, the plant way of eating will create a diversity of that microbiota that really fosters the best postbiotic production of transmitters and protection that population of organisms can provide. And in this particular set of circumstances, it's a very powerful component.
Yeah. On a simple micro pain level, I have a patient of mine who's unfortunately in his 40s, and he's got some early arthritis in his knee. And he's probably 99% plant-based, whole food plant-based. And I just saw him not too long ago. And I said, he said, you know what? I've just realized that if I just one day would slip, go to a barbecue, whatever, and eat a cheeseburger, my knee the next couple days just hurts. He's like, it's clearly has an impact,
Right.
it affects the pain. And so on so many different levels, it helps people feel better and they have more energy, and it just starts to cascade. I had a patient of mine on a recent podcast. She came in really severe fibromyalgia, and she had a lot of these comorbid issues, but she was referred by a friend, severely obese. She went from about 290 to about 220 pounds over 9 months. And she said to me, and using a whole food plant-based diet, along with graduated increase in her exercise, completely reversed her fibromyalgia. And she said to me about 9 months after I first visit with her, she said, Dr. Lenz, I want to run a 5K and wear a bikini. And that's not the goal I've ever had for my patients, lose weight, get this. But it's just, those are those stories that this is just somebody who went from really down. She had a lot of trauma in her life, and you can hear the story in a recent podcast, but those are those success stories. Like, hey, this is the stuff that can work. And so incorporating that, I guess where somebody's at, I try to get a gauge of where they're at. And I'd say, well, can you have oatmeal? What about oatmeal for breakfast? And start with the meal. And then, there's things like the 21-day vegan kickstart by PCRM and other things. And all those are entry level, seeing where they're at. And then if they pause and I said, you know what, the more you can do, the better. And I'm always trying to, everybody's that individual, and you don't want to lose them as an all or none. You kind of have to feel that out and support to whatever level and degree. Or you can say, well, let's try an experiment for about 3 weeks and see what happens,
And I tell people that too, because it is experiential. We could lecture till we're blue in the face. And if what we're saying is adopted by them and they're not getting some of the results we're actually telling them they're going to get, they're not going to follow it anyway. But that's the thing. The proof is in the pudding. So when you really set it in motion, you do start to feel less painful. You do start to feel more viable. You start to feel more hopeful. I mean, you're talking about people that have lost hope over such a long period of time in some cases.
Yeah.
That just instilling and sharing that biology of hope is such a profound experience.
And I guess I'm thinking of the withdrawal thing. If you stop a whole food plant-based diet, you get withdrawal. you get back. You
get
start
a lot
feeling
of pain.
sick.
You get a lot of pain, baby. Yeah, you do. That's true.
I've had patients of mine who thought that feeling full was when they were feeling sick.
Right.
Like, I can't have any. I'm sick. You switch to a whole food plant-based diet, it's like, I'm just not hungry. Right. I don't get sick. I don't feel full. And it's one of these until they do it. And then they slip, they go to a vacation or whatever, and then they have a little flare up of whatever it is. And they go, well, that's not worth it. Just like somebody smoking cigarettes and having an asthma attack.
And sometimes you have to have those experiences to reinforce that this is the path you really need to stay with. I think it builds its own compliance in its own way. Well, Micheal, as we wind this down, do you have any final words or insights or things you want to share with the audience out here?
Yeah, for those of you who are struggling with chronic fibromyalgia and all of those bucket of related invisible illnesses, knowing, hey, there's a doctor out here, and if you want to learn more, encourage you to dive in. And hopefully, if you have a sympathetic doctor who just hasn't had the training, they can hopefully dive more and work with you and help and grow in the understanding that hopefully this will be the standard, just like we realize that depression's real and that we don't just blow them off, that this is real. There's real answers, real solutions, evidence-based, and hey, try an experiment. We're not selling any fancy supplement at the end of the book. It's just trying to incorporate that. And also, if you have any ideas for podcast episodes or anything you want to reach out to me, you can connect to me. I'd love to hear from you.
Okay. Well, I want to thank my guest, Dr. Micheal Lenz, today for sharing his expertise, his wisdom, his heart, and really all the information that he's put in this incredible book called Conquering Your Fibromyalgia. I urge you to follow Dr. Lenz on the website that you'll see in the show notes that we're sharing with you. And if you have been someone suffering with any of this or any family members or friends, he's the guy you want to kind of follow through with. And the book itself is really magical for really explaining the black box of so much of what people have been suffering with for so long. And I really want to thank our audience and the people that joined us today. Without you, we can't do what we do. I want to thank you for being part of this active, healthy community. And on behalf of the National Health Association, I'm your host, Dr. Frank Sabatino, and I look forward to being with you on the next episode of the Health Science Podcast. Thank you, Micheal. I appreciate it so much. Thank you.
Thank you.
You've been listening to the Health Science Podcast, brought to you by the National Health Association. Thank you for joining us today and for your commitment to evidence-based health science that backs a whole food, plant-exclusive lifestyle and contributes to the well-being of all people, animals, and our environment. I'm your host, Dr. Frank Sabatino. Be sure to leave a rating and a review, and we'll see you on the next show.